I mean, I think the current status nationally and locally is we continue to see cases. We are still trying to be vigilant in efficiently evaluating patients when they do come through our health system. But again, I think even around the city, other institutions are seeing patients as well.
I wanted to ask you a question about the difference between quarantine and home isolation. People are using those terms, throwing them around. Can you help people understand the difference?
Self-quarantine and self-isolation?
Yeah, we talking about self-quarantine, self-home isolation, home quarantine. What's the difference between the two?
I mean, at this point, there's not a lot of distinction between the two, of self-quarantine and self-isolation. Self-quarantine maybe more for people who either think they have been exposed or are doing quarantine to try and prevent exposure. Self-isolation tends to be more people who are ill, trying to keep others from getting ill, self-isolating at home, even if that's in the same household where there are other people living. Trying to do measures such as living or staying in different areas of the household, if that's able to, appropriately wiping things down and cleaning after you've been in that area. And so that's kind of where we're going. Everything kind of gets muddled into one kind of description at this point, though.
Dr. Hawkins, it's Mike Sherry at Kansas State Public Television. How you doing?
Hi.
Say, can you put you recorded in the Star today talking about we haven't seen the peak. I mean, or that we could be like Seattle. I mean, what? I mean, are we talking about 20% more infections, 30%? What are we talking about here until we see what the peak?
I don't think we know the peak yet. That is one of the questions, along with many others, about the infection itself and the virus. I don't think that epidemiologically and from a public health standpoint, we do know what the peak is or when that will be. Again, all these measures for individual healthy behavior, for social distancing, these are all aimed towards decreasing that whenever it may be and slowing it as much as possible as well.
But you did say today in the paper that you thought we would be like Seattle.
Yeah, I mean, based on just in general how things are going around the nation, and these numbers change and these assessments change sometimes twice a day, sometimes daily. You know, we just don't know. We are trying to continue to do what we can to decrease the number of new infections.
I actually think what we said, the curve for the United States is looking like the curve in other places that are bad. And if we can flatten the curve, and this is our opportunity to flatten the curve, then we can really improve what that number looks like. We're 7 to 10 days behind New York. New York has over 4,000 cases. Kansas is at 44 cases right now, and a jump of 11 in the last 4 hours. And of course, a lot of that just has to do with reporting. But, you know, there's a difference between 44 and over 4,000, and the difference is that we're at a different phase of the disease, and we have an opportunity to us that is granted to us because we can see what's going on the coast to take action. And the action has to be to stay inside, don't go out in big groups, don't go out and do things like that, because that's what's going to spread the disease. You've got to stay inside, you've got to wash your hands, you've got to not touch your face, you've got to be socially and practice social distancing. And that's not a lot of fun, but it is the requirement if we want to shorten the length of the highest intensity of this. And remember, the reason you want to do that.
Dr. Stites, I'm sorry.
It is.
Yes, Dr. Steve Stites is on now.
Sorry. The reason you want to do that is you don't want to exceed the ability to take care of people in intensive care, in critical care, with the number of ventilators, the number of ICU resources that you have.
Hi there, this is Kat Reed with 41 Action News. I had a quick question, speaking of resources with ICU beds and ventilators. You know, looking at Kansas, we have some rural communities that don't have ICU beds, that don't have some of the access or technology. And I was curious if KU, University of Kansas Health System, is considering some of our other rural counties and preparing for an influx of those folks to come to the facility.
I think we're all doing what we would call, I don't want to use the term disaster, but ICU planning like that. We've formed a task force here in the metropolitan area to think about how we can share ventilators and things like that and go back and forth between one health system or one hospital and another, which normally is not something we would do, but under the federal declarations I think as I understand this, of the medical, or whatever that Federal Declaration of Emergency Act, thank you, that we have a little bit more latitude in some of that. We also are actively working with our health system hospitals in this regard to make sure that we know we have a plan from going from a critical access hospital that doesn't really do this kind of critical care to the nearest referral hubs, be that Hayes or Topeka or wherever that may be.
Dan Margulies at KCUR. I have a question about CMS's announcement a couple of days ago that elective procedures should be postponed. It appears most of the hospitals in the Kansas City area are doing that, but not all. Could either of you comment on that?
I was on a regional call this morning with different chief medical officers, and I would echo that most hospitals are planning to do that. We started canceling cases Monday. I don't remember the exact number, but our OR is running around 25% of capacity right now, and that's because we have a 75 or thereabouts. The exact number I don't know right off the top of my head, but about a 75% reduction in surgical case volume, and almost all of that is in the elective arena. And so, as a reason, we're a little lucky because it was spring break, so a lot of surgeons were out of town anyway. So that was a blessing. But we started canceling our elective cases on Monday. What we've done is really prioritize them into one of three categories, and I think that got picked up by the American College of Surgeons, and they're doing recommending the same. Level tier 1 would be those people who really can be wait. There's no real risk or harm to that. You have to postpone it. Tier 2 is cases where there may be some risk of harm, and the physician and the patient have to make an informed decision about what that relative risk and harm is. And Tier 3 means you got to go ahead and do it. And so, like cases that you have to do are cancer surgeries. You can't let somebody's tumor grow, and et cetera. And Tier 1 may be a cosmetic surgery or something like that. So we have made that effort to cancel all elective surgeries, and the real reason for doing that, to be clear, is that we have a problem with the amount of personal protective equipment. Now, we're okay, but we're trying to conserve as much as we can right now for the eventual rapid increase in the number of COVID-19 patients inside the hospital. And that's really important. That the reason we've been holding back surgeries is in order to preserve our personal protective equipment. I don't know, Dane, if you have anything to add to that.
I second that overall statement. Yeah.
I have a question.
Who was that speaking just now?
That was Steve Stites. Sorry.
Got it. And then Kat Reed with 41 again here. I just was curious if you could maybe comment on, I know hospitals nationwide have a shortage of some of the protective gear. I'm curious what the supply chain looks like right now. I know in Washington, some physicians have turned to even using office supplies to create their own protective gear. Are we at that dire of a situation yet?
Okay. Yeah, again, we've known and we've been preparing for this for weeks, for years, for these types of emerging infectious disease and other disaster problems. We have contingencies in place. We have resource conservation plans in place. At this point in time, we are continuing to follow those plans. We are trying to conserve our resources as much as possible. Dr. Stites talked about the elective surgeries that we're not doing. And so we have a lot of different components and details of these plans to try and conserve the resources as much as possible so that our healthcare workers are safe and they have the personal protective equipment that they need. And we're continuing to do that. At this point, we are not anticipating or hoping to have to use office equipment, as you said. We are continuing with our plan to try and conserve the correct personal protective equipment as much as possible. to keep our healthcare workers safe when treating these patients.
Would you all, this is Mike Terry with KCPT again, would you all mind talking a little bit more? I think Dr. Stites mentioned it, the regional effort on the ventilators. I mean, what does that, what's new about that, and what are y'all doing?
It's just very preliminary. We've only had one meeting so far on it, but our goal is to see if we can, kind of retain a ventilator count for how many ventilators are out there. And I don't know who will do it. I'd prefer not to talk too much about it. Just say efforts are underway to create a group of critical care physicians to look at how every health system or hospital is doing with regard to their supply of ventilators. Because it's so early. I mean, they had their first call this morning, and I don't want to get people all concerned about what we're doing until we have a lot more opportunity to stand that up, right? I'm just trying to let you know that everybody's involved and all hospitals are involved. Same thing, we have a CMO group. It's just starting to stand up. I got to tell you, the level of cooperation between us has been outstanding.
These are regional hospitals both on the Missouri and Kansas side?
Yeah, it's a lot of different folks. And again, it's so early. I'm reluctant to talk about it too much. I would really ask your indulgence. I mean, I'm telling you that, but it really is, I don't want to spook people from talking about it right now.
I mean, I think it would help for people to know you guys are talking about it.
I understand, but I also don't want to spook the people who are helping us do this and put it together, right? I think that trumps to me, to be honest. So I ask that you indulge with us about this, and when we get this more stood up, we'll be happy to talk about it more and get other people around the table. But right now, I don't want to regret talking about it or even mentioning it. So I'm going to have to ask you to indulge me on that, please.
And it's also, if people will focus on...
Excuse me, can you hear me?
Yes.
Hi, this is Cindy Gregorian with The Beacon. We're a news website in Kansas City. Have you received any word from anyone, manufacturers, the government? I know there's a push to get 3M and some of the companies that make N95 respirators. Are you going to be getting more of them? And if you don't, do you expect to run out? And if you do, what will you do? Will you be reusing them beyond recommended guidelines?
I'll comment on the supply chain, and Dana can comment on the guidelines part of this. We're in contact with these folks all the time, trying to ask how things are going, and I'm hopeful that in whatever period of time there will be a better supply. Right now, it's short. We do have a pandemic supply that we can access here within our own health system that we have stored. So we may have to get into that. Hopefully not. Hopefully we'll be able to maintain our stock without it, but it's there. There's also a county-wide stockpile, and from that there's a regional county stockpile, and from that there's a state stockpile, and from that there's a national stockpile. And so there are ways you can go to get to those folks, but I think that there are supplies that can be accessed depending upon the degree of need. But to point out, this is a national problem. This is not just a local or regional problem. Somebody mentioned a while back about people at Washington trying to put together their own special protective equipment. And we've all heard those stories, and our goal is to try and make sure that the equipment we use truly is safe. And to that, we need to turn to our medical suppliers as most we can. Dana?
Yeah, and I'll just kind of talk about that as well. I just earlier mentioned about our contingencies and our protocols and our plan to conserve PPE, because it is vitally important. We have many aspects of these protocols and these plans in place. Reducing our number of elective surgeries we've talked about, reducing the non-essential people for seeing the patients to try and conserve and keep these personal protective equipment items so that the people who really need to be treating the patient and seeing the patient on a daily basis have that. This is all part of that plan. I don't think we anticipate having to use any masks or any PPE beyond the guidelines. We are certainly still very aggressively working to conserve the stuff that we have and work as we need to continue to keep our healthcare workers safe when they are seeing these patients. And I would like to also remind you that it's important that we have to remember that this virus, this infection, is really consistently thought to be infectious by droplets. So we don't need N95s if you're not going to be doing aerosolizing procedures. We don't need those. We need surgical masks, we need gown and gloves, and we need adequate hand washing. So the N95s is not the focus of this. And in general, it should also, we need to remember that the majority of these infections are not going to need hospitalization. Certainly we know there's subpopulations that are at more risk. We know that individuals sometimes are at more risk. But we would still encourage the public to stay home if you're not feeling well. Please, by all means, call your provider. If you need emergency medical attention, please call 911 or come to the emergency department, but call ahead. But the majority of these infections are still going to be able to be managed at home, just as you would another cold or flu or any other mild illness. And by doing that, that will also help us to conserve our PPE as well.
So let me just pile on to what Dana said. You know, the questions are really aimed at, do we have enough of this, do we have enough of that, do we have enough of this? And those are good and fair and honest questions, and appreciate that. I want to point out, though, that the issue isn't really how much supply. I mean, it's an important issue. The real issue we have to address is back to what we were talking about. How do you flatten the curve? If you don't want to be Italy and you want to be more like South Korea or Japan, what is it you have to do? And you can see it out on the coast, right? You can see what's happening in California with lockdown, in New York that's headed, it feels like they're headed that way, and other states. The answer to the question is, what can the average person do to beat corona? How do you control coronavirus? How do you beat corona? The way you do it is to stay home and distance yourself. Going out to bars, going out to large groups, that's a really bad idea right now. And I'm not trying to be alarmist, I'm just trying to be really honest about it. If you want to make sure that you and your family and your friends and your loved ones get through the coronavirus pandemic, the thing you have to do is not be in a position to spread or have other people who have spread the virus affect you. And the way you do that is you stay at home and you distance yourself from folks and you wash your hands. That works. All the other stuff like N95 masks and ventilators, we only get into that real problem if people don't do what we're asking them to do. If they'll do that, we'll control this. But without it, yeah, we're going to struggle, right? That's going to be hard.
And again, I'd just like to speak anecdotally too. You know, again, the most consistent thought at this point in time is that this virus is spread among respiratory droplets. It's not airborne.
Tell people what that means.
So that means when you're coughing or sneezing, you will have certain very, very small particle sizes of secretions that come out when you do cough or sneeze. We know the average size of these particles, but what in general it means is that they do not stay in the air or airborne for a long period of time, but rather drop down to surfaces. And as I'm seeing more and more of these patients in the hospital now, I can tell you that I am more convinced than ever that this disease is spread because people are touching surfaces, they're wiping their hands and their face. Most people who probably have gotten the disease will probably tell you, yeah, I don't remember anybody coughing or sneezing in my face. And so I think that as we continue to move forward, the most important thing to do is to continue to have good hand hygiene with either soap and water or alcohol gels, and make a conscious effort to do that frequently throughout the day, as well as not touching your hands to your eyes and your nose and your mouth.
This goes back. Oh, sorry. Go ahead.
Oh, okay. I'm sorry. Go ahead. I'm sorry.
This is Mike Sherry again. Well, I mean, I know we're talking about preventive measures and things, but there has been discussion about, the need outstripping demand for hospital beds. I mean, has KU? I mean, I know the preventive surgeries are like that, but is there any concern that it could spike so much that you wouldn't have enough beds?
I mean, are we concerned about that? Of course. I mean, what do we say? Yes. But that will happen if we don't take out the opportunity that we have over the next, and this is critical, folks. We have a short runway. This is our opportunity to control that. And if we wait for 2 weeks or 10 days, yeah, we will have blown the opportunity. And so we really have to take action now to do these things. Do we get worried? Of course we do. Do we have to think about disaster planning? You bet. And we spend hours doing it every day. But the real planning needs to be done, and we need your help. We got to have everybody's help to make the narrative not about the panic around no beds. It's the need to stay home. That's got to be the narrative.
And this is Carolyn from KCTV5.
Hold on, and it's so vitally important to adhere to what our public health guidance is, and listen to Dr. Stites. And these are very difficult decisions. If you are not in a household with other people who you're seeing on a regular basis, if you have a boyfriend or a girlfriend or friends that you want to see, it's hard to be able to do that at this point in time. But you just don't know, and a lot of people don't ever know where they came into contact with this and could be ill. And so by making these hard decisions and staying home and not having contact at this point in time is the best way to stop the spread. And then eventually, as Dr. Stites had talked about, we don't necessarily have to have the conversation about a shortfall of beds and ventilators and other resources.
You had mentioned you had mentioned the increased lockdown in California and in New York. Do you think we're falling short then here in the metro area of not just doing that now here to prevent it from getting any worse?
Yeah, I think that's a public health discussion and a governmental discussion. My urge is whether a government official tells you to stay home or not, the answer is that as a medical professional, I can say the best way to avoid coronavirus is to stay home. Hopefully you don't have to have a lot of people telling you to do that. But that is a personal response to me, a personal choice that we all have, and our advice is to stay home. I'll leave it to the political officials have to decide about lockdown and all that stuff. But as citizens of a community, to me, that's a question of personal responsibility, and are we going to be responsible enough to stay home now so we take care of each other later?
Can I ask you a quick question? Because part of that for us personally here at the hospital is visitation, and the public's starting to get a little
Yes.
wound up about that, and we're tightening those restrictions.
We
and
have.
That's not going over well when you have somebody in the hospital, we can imagine, but tell us why that's so important. And
it's so hard, right? I mean, none of us, I think about my own family, if they were here, how devastated I would be that I couldn't be in the room and with them the entire time. And that's hard. And some of us have had enough illness in our family that we get what that means and how lonely you can be. The flip side is that if you bring disease into the hospital, you create an environment where other people pick it up. Who have we helped and who have we hurt? And so these decisions about zero visitors, they're really hard. We don't do that lightly. We didn't want to do that. We tried to resist it. But the evidence from the CDC in Washington and New York was inescapable that we needed to do that.
Oh, whoops, yeah, no, I was wrong. Sorry.
Hey, can you guys mute your lines?
Turn right up here.
Somebody's got an open line. Can you mute your lines when you're not talking? Thanks.
I have another quick question. I just wanted to circle back to make sure that I'm 100% clear. So is it not reportable at this point that there are just very early meetings going on to discuss like resource sharing with the rural providers?
Well, again, there are always discussions going on with KDHE and different hospitals about how they would share equipment and how they transfer patients. We do that on a regular basis all the time for sick patients. That's not a big deal. The big deal, I think that the importance of this is that hospitals from different groups are looking at each other as colleagues and not competitors and saying, how do we take care of an entire region? How do we do that? And I think we're having those very early conversations and thinking, gosh, we got to stand this up. And so that I'm comfortable saying because it's true. I just don't want to draw a lot of conclusions to say, hey, we've done all this. Well, that's not true. We're getting ready to try it. And we'll work with all our government entities, the Kansas Hospital Association, the Missouri Hospital Association, the KDHE, the Missouri Department of Health. We'll work with everybody we can to do that.
Thank you.
Any other questions?
Yes. Are surgical masks as good as the N95 respirators at protecting you guys when you're treating patients?
Well, I mean, that's a difficult question to answer in the fact that in what situations are we talking about that? So again, I am seeing quite a few patients now with COVID-19. I am going into a room with a surgical mask, as well as with eye protection, a gown, and gloves. I feel very comfortable that that is enough and adequate protection for me. Now, there are instances when we would prefer to have airborne precautions, which is either an N95, which, by the way, is not just something you can go buy off the shelf and use it. This is a piece of PPE that needs to be fit tested. We need to do testing to make sure that particles don't get through. And that is, that is mandated. That is something that has to be done for anybody who wears it. Even in the hospital, we have to fit test the people that are wearing it. So either for airborne precautions, either an N95 mask or a PAPR, which is a large hood with a battery pack and something to help with air in a respirator. But those are typically only needed when you are generating aerosols. So for instance, if you are intubating a patient, if you're doing bronchoscopy when you're looking down their lungs, if you're giving nebulizer medical treatments to people. So those are very specific instances when we really need to be using the airborne precautions. The guidelines would still be consistent with if there's no aerosol generation by a specific procedure, then just a typical surgical mask is more than adequate. And again, I do feel very safe when I'm seeing my patients just wearing the surgical mask, wearing the eye protection, wearing the gown and gloves, but most importantly, doing the hand hygiene before putting on all of the PPE and after taking off all the PPE.
Do you have more surgical masks than you do the N95s?
I think so. In
Yeah,
general,
I think we do a
yes.
lot more surgical masks because there are more patients who aren't having those things and aren't the most critically ill, or are just hospitalized, and I think we feel safe with that. So yeah, there's a lot more volume of surgical masks. So.
Are you using telemedicine?
And they can be reused more?
Well, they're not reused.
No, they're again, for the surgical masks, we're not reusing them. So there's not a lot of data, but typically those masks really start to break down after about 2 hours. But once they get wet or moist, they are no longer viable to work because they just act like a wick, just soaking up stuff. So as a short answer to that, no, we aren't reusing surgical masks.
So, one thing is an example of trying to make sure, Dana, people don't get sick and that they don't get sick coming to the doctor and yet maintain appointments is the expansion in the telemedicine. And over the next few weeks, we're going to roll out our telemedicine platform, which will allow almost 100% of patients, if needed, to be seen, and our ambulatory clinic schedules, which we've been canceling everybody from having to come up here, or a large proportion of those patients. Over half of our clinic visits have been canceled at this point because we thought that's better for patient safety. In the long run, though, you can't keep doing that. And so our telemedicine platform over the next 2 weeks will roll out. We believe we can have 100% of our appointments, and we don't want to really do 100%, but if we could do 100% of appointments based on a telemedicine platform, that would allow us to be talking to our patients and seeing patients as if it were a clinic visit. And so we're hopeful that will help us and help all of our patients throughout the area.
Can you identify COVID patients through telemedicine? Is that effective or no?
Well, I don't know that. No, you got to get the COVID testing. The problem with coronavirus is it's coronavirus, and there's other forms of coronavirus, and it presents pretty similarly. So you can't really tell you've got the SARS-CoV-2.
Would you be able to tell if they would be somebody who would need to be tested via
Yeah, I
telemedicine?
think we can. I think that could be aided. And then after you're diagnosed, if you're at home, we have a COVID-19 follow-up clinic. They'll allow us to monitor how patients are at home, and that's started. So I think that's one of our ways to make sure people are safe at home.
Dr. Stites, you mentioned, when you said roll out telemedicine, I mean, you all have telemedicine. Are you just talking about ramping it up, or what do you mean when you...
Yeah, you're right. That's actually a better turn of phrase than the one I used. Thank you. It is a ramp up because we do have it currently, but our teams that took a 1.5 year rollout, that's better, how's that? 1.5 year ramp up for going where we are to where we wanted to be and compress that into 2 weeks. And there's about 70 people working 24/7 to get that done. And that's driven solely by the need of our trying to get back to our patients and make sure we can take care of them.
So you're trying to compress a 1.5-year time frame to get it up and running into about 2 weeks.
Yes, sir.
Or, I mean, not up and running, but to the full expansion that you'd want it to be.
Yeah, as full as we can over that time period that'll allow us to see patients on different platforms. And in fairness to our governmental officials, they've changed billing codes. That was part of what was standing in our way, just to be really honest, that there were only certain kinds of ways you could do it. They've liberalized those so we could do telemedicine, and that's really opened the door for us. So.
Yeah.
Yeah.
we
Thank
gotta
you.
go.